The FDA Endocrine Advisory Committee voted against recommending approval of once-weekly insulin icodec for treatment in people with type 1 diabetes. The vote was 7-4, and the reason that people voted against it was because there was an increased risk for hypoglycemia with the once-weekly icodec compared to standard therapy. Now, the data for this comes from the Onwards 6 trial, in which they took 582 people with type 1 diabetes and randomized them to one of two regimens. One regimen was icodec plus premeal insulin aspart, and one was insulin degludec plus premeal insulin aspart. They followed the patients for a year and found that overall, in terms of glucose control, there was no difference between the two groups, except the patients on icodec had a higher rate for hypoglycemia, both mild and severe. The increased risk for hypoglycemia seems to have happened because once-weekly icodec has something of a peak. It has a peak glucose-lowering effect that is seen 2 to 4 days after injection. And this is even once people are at steady state. And during that period of time, there's an increased risk for hypoglycemia. And during that period of time, theoretically, patients would have to give less rapid-acting insulin to account for the fact that there was more of an effect of the long-acting insulin. But this is somewhat hard for people to do, at least I think hard for people to do who aren't in a clinical trial. So in overall terms of safety, there was no imbalance in terms of death or other SAEs, excluding hypoglycemia or discontinuations. But at week 57, insulin icodec had a 50% higher incidence rate and an 80% higher event rate of hypoglycemia. These higher rates were observed regardless of whether the hypoglycemia was captured versus finger-stick glucose monitoring or CGM. The risk was greater 2 to 4 days following each weekly injection, and the time below range throughout, meaning below 54, was higher in the insulin icodec arm. The episodes of hypoglycemia were similar in duration, management, and recovery. They just were more frequent in the patients on the icodec. So there are some proposals to try to figure out how to mitigate the hypoglycemia risk. And I think they're a bit complicated, if you ask me, but they make some sense. So the patients with the highest coefficient of variation did the worst. And so one way to mitigate some of the risk is to choose only patients who have a lower coefficient of variation, meaning a coefficient of variation of less than or equal to 36%. And all people on this insulin would need to be on a continuous glucose monitor so that they could deal with this increased risk for hypoglycemia. People who have a history of hypoglycemia unawareness or episodes of severe hypoglycemia shouldn't take it. I think that obviously if people are having hypoglycemic events that can't be mitigated, it should be stopped. And then I just think that education would be vital here because people would need to give somewhat less insulin on days 2 to 4 after the weekly injection. These are recommendations that the company had. I think that it might work if this was given more often, like twice a week, although that's hard to do. And I want to point out that I'm talking about people with type 1 diabetes. I think this actually would work better in people with type 2 diabetes, and the clinical trials have shown that there is not an increased risk for hypoglycemia in people with type 2 diabetes. And I like the idea for people on basal insulin who are on a once weekly form of incretin therapy to give them both together. That makes a lot of sense to me. But in these type 1s, there was this problem. And I've long been hoping that once weekly insulin could help my patients who are at risk for DKA and other complications just have some sort of basal insulin in their system. But I'd have to see how this worked, and I'd have to see how we really dealt with this risk for hypoglycemia, because hypoglycemia is the thing that most limits my patients' use of insulin. So this has been Dr. Ann Peters for Medscape. Thank you.